Hello and welcome to our 5th Planetary Health Lecture in the Planetary Health Academy. And today we're going to focus on clinical planetary health, which is especially important during these days, actually, as well as we are facing a heat wave here in Germany and probably in other parts of Europe as well. So today we're going to focus on internal medicine, but actually not so much on heat, but on all the other different aspects that are important in internal medicine. So, for example, allergies, cardiovascular diseases, and infections. So we're really happy and glad to welcome 3 doctors that normally work in the hospital in their everyday life for today. And we will start with Claudia Traidl-Hoffmann. And I will just give a short introduction and then will hand over to you, Claudia. So you're a dermatologist and allergologist, kind of, I guess you would say in English. And you are currently working on a textbook together with Martin and actually all the other doctors here as well. So Thomas Münzel and Clarissa Costa as well, on the topic of planetary health and climate change and health. And you also just recently published a textbook for more the public audience on the topic of climate change and health. So you're already you've been joining us for quite some years already, I would say. So you also experienced this shift in this shift in awareness on this topic. Maybe you can share a little bit on this as well, like how you experienced this last months where so much changed and the awareness on this topic just rose dramatically, you can almost say. And just for your affiliation as well, to mention that you're working at the University of Augsburg at the Department of Environmental Medicine and also at the Helmholtz Institute in Munich. So thank you for joining us.
Sylvia, it's an honor and pleasure to be here. Actually, you KLUG, you Sylvia Hartmann, you are organizing it really in an excellent way to give here a platform to discuss on climate change and health, and to give now we are almost 300 people here in this Zoom room, to give so many people the possibility to learn and to discuss about climate change and health. And actually, yes, my son just came home from work, and he's doing he's learning electrical, so not engineering, but so he's working also in houses and also outside, and he is already suffering a lot. And I think he is standing for so many people that are now working outside in the sun. And I think this is why we have to understand how heat, sun, and all the environmental factors are impacting on our health. And this is also what I see not only here at home with my son, but also with my patients. And but as you said, Sylvia, we are experiencing at the moment a really let's say a tsunami in medicine. People are getting more and more aware, and I'm one of the people being in this tsunami, and I'm really glad to join also KLUG. I'm also a member and part of KLUG, and it's for me also a kind of therapy against this this fear we have also that climate change is also cutting our existence, let's say, of humanity. And this is why I'm really happy to be active with you and the colleagues. And this is what is getting every day more evident. But let me speak about the topic I would like and can speak about today, because I am dermatologist and allergologist, and I can really tell you that climate change is a challenge for allergics, but not only for allergics, but also for us as medical doctors. And I would like to share with you some recent and data, but also the pure and crude evidence how climate change is impacting on our health. Sylvia, you mentioned that we just published here this German book. It's only in German, yet together with Claudia Traidl, And you also mentioned our book on planetary health, and this is only a provisional cover, but it will be released in October, September, and will be for clinicians, for people working in the medical sector. And I hope that we really bring here something to you also in the audience that will help you to tackle your daily life with patients. And this is what this book is also good for. And I'm really honored that I'm heading this together with Christian Schulz, Martin Herrmann, and Babette Simon. Good. This said, let's concentrate now on another tsunami, just with this the allergy epidemic, which is really coming towards us like a tsunami. We are already in Europe, 40% of people having a kind of allergy. We have 30% of kids with atopic eczema, and all environmental diseases are increasing further. So this is something we have to tackle every day in our outpatient clinic. People suffering from allergies at the moment, and I can tell you, my patients with atopic eczema, and they really have depressions apart from the itching, and I have also patients that would like to end their lives because of this heat and the inflammation on the skin. And this is why we have really to treat them, and we have also to mitigate climate change. So allergy is a classical environmental disease. They are impacted by psychosocial factors, by anthropogenic factors, by biogenic factors, but also by nutrition, and also and only by really seeing this disease as an environmental disease, and also in this complexity, we can understand the disease and also treat the disease. And even better, when you think of 40% being allergic, we have to prevent allergic diseases. And this is something which is getting more and more, and every day more difficult to prevent because of the effects of the climate change on ecosystems and on us. A little reminder, what is allergy? So one allergy that is really impacted by climate change is pollen allergy, and normally pollen are flying through the air and landing on mucosa, on the surface of the stigma, and then transmitting the male genetic information to the plants. So this is what is normal, let's say. This is for what they were invented, let's say. But when they are flying through the air, like at the moment, grass pollen, so this is a birch pollen, when the pollen are landing on the mucosal surfaces, they are releasing a lot of substances, proteins foremost, that are getting into contact with dendritic cells. And these allergens are taken up by the dendritic cells, are presenting the allergen to T cells. And these T cells are Th2 cells, so interleukin 4 producing T cells. And these are then instructing B cells to produce IgE. And the IgE is the antibody that is then bound to mast cells. And these mast cells are then, let's say, ready to go because then sensitization was successful. And now in the second and every further encounter with pollen, this cells then release mediators that then here you see there's a cross-linking of the two antibodies. The mediators are released, and then the disease and the inflammation starts. So this is the first important message to you, that allergy is a two-step mechanism. So first of all, you get sensitized, and this sensitization can be investigated by serum and the antibodies you see in the serum. But the sole positivity for IgE, specific IgE, does not mean that you are allergic. It's more the disease. So sneezing, for example, or asthma or urticaria, this is the disease. And this is important. So I will go with you quickly through 5 topics: pollution and climate change and allergic diseases, pollen and climate change, thunderstorm asthma, pollen and virus, and also safe places. So this is important for you to know that in allergy, it is like this, that the climate change is impacting on ecosystems, and also pollution is impacting on ecosystems, is increasing the allergenicity of pollen grains, for example. But at the same time, these factors are impacting on our health. So this is a Janus phase role, let's say, of climate change, on the one hand impacting on us directly, but on the other hand also impacting on ecosystems, and by this on our hearts. So this is a classical example on how climate change is increasing allergenicity. You see here these plants that were exposed to future climate conditions. This is CO2. We put also nitric oxide, and we exposed ambrosia pollen to these, let's say, climate gases. And you see here that by doing this, these high CO2 pollen, they lead to a higher loss of tolerance, but they also lead to increased inflammation here in our systems. So this is a clear sign how climate change is then impacting on our ecosystem. On the other hand, we know, and this is a patient, a young patient with atopic eczema, which is the, let's say, the door opener for allergic diseases. We see at the moment 30% of patients with atopic eczema in Germany and Europe. Also in the global south, atopic eczema is increasing actually. And we know that pollution is reducing the barrier function of the skin, and by this also increasing the probability to develop allergic diseases. Another really important point is the loss of biodiversity. Also, this is something by which we can explain the impact of climate change and pollution on ecosystems and then on our health. And this is really a circle of causality we have through the urban life and reduced contacts with nature. We have poor microbiota in our gut and on our skin. Then we have immune imbalance with more Th2 cells, and then the inflammation. And then we see these patients in our clinic. And this is something we also see really by epidemiological studies here, the comparison of the Russians and the Finnish Karelia. And you see that the Russians, which are in this region of Russia, they are really traditionally living with a lot of contact to animals, to ground, let's say. They have really a low sensitization rate, while the Finnish Karelia, they have an increasing sensitization rate over years, and this is a bigger publication. This is correlated with reduced contact to nature, with reduced biodiversity in the environment. So in summary, we know that diversity is good. The loss of diversity, however, is bad for the development of allergic diseases. And this really has an impact on ecosystems. You see that we have more pollen, we have more spores, but we have also new pollen. And this is something we are seeing also in our clinic. So I see more and more patients suffering from ambrosia. This is Traubenkraut, ambrosia allergy. And the problem is that this ambrosia pollen is so small that it's getting into deeper parts of the lung and inducing really strong asthma attacks. And this is how the patients that are sensitized are in most of the cases going directly to a strong asthmatic disease. Also, urbanization has a strong impact on the ecosystems. You see that the flowering start is earlier in urbanized areas. And this means also that our patients in urban areas are suffering earlier in the year because of the earlier flowering of the pollen. And the prospect is bad. We see here in 2050 even more pollen, and this is Bavaria, but we can show this also not only for Germany, but also for whole Europe. And there's another publication of colleagues of us for North America. Why is this important to look also for urban areas? Because people in some years are only or for most living in urban areas, and we have also a correlation of wheezing, so of symptoms of patients here in urbanized areas, higher symptoms, more wheezing compared to rural areas. So this is really something we are seeing with our patients, and this is why we need really good urban planning, and this is what I would say is not so good here in Potsdam. This the Potsdamer Platz, birch trees in Berlin instead of trees that are not inducing allergic diseases. I would say, because the introduction was so long, I will now concentrate again here on the thunderstorm asthma, because also this is something we are seeing with our patients. This is an important story, first described in Australia, the thunderstorm asthma. Important is that these patients that develop thunderstorm asthma, so asthma during thunderstorms and high pollen concentrations in the air. The important thing is for our patient that it can occur also in patients that are not sensitized, that have no allergies. And this is also explained by the fact that possibly the induction of this thunderstorm asthma is not an allergic reaction, but because of really small particles that are going in deep parts of the lung. And this is apparently also due to electromagnetic fields due to the thunderstorm. And by this, we have this strong asthmatic reactions. And without going into detail, but we see this not only in Australia, where there were also deaths during thunderstorm. We see this also here in Germany, and especially in Augsburg. So to explain this to you a little bit closer and better, here you see the grass pollen concentrations. Here the highest concentration, the lightnings, here the highest lightnings, and then the symptom score. And you see here, and that there, when the lightnings are high, grass pollen are high, we see also the highest symptom score in this complex analysis. The interesting thing is we see this also without pollen. So apparently only lightning, so only thunderstorm without pollen also increases the probability of asthma. What has thunderstorm to do with climate change? So it's extreme weather events, and this is why we are investigating this, because of the impact of these extreme weather events on health. Connecting also pollen with the pandemic, I think it's important to know that people are getting more prone, more sensitive for the development of infectious diseases when pollen are present. So we know that pollen are blocking type 1 and type 3 interferons on the mucosal surfaces. And this means when pollen are high, we see more rhinovirus infections. This is a publication here from 2020 and just now published. We see also higher SARS-CoV-2 infection rates when pollen are high. And this is really a huge and large study over 5 continents. yes, concentrated on Europe, to be honest, but we see this also in other regions of the world. And one important message is the infection rates were there lower, where also the pollen were lower. And this is how you can connect the impact on climate change on pollen counts, for example, and the susceptibility for viral infections. And I think especially in springtime, this has a really high importance. And I'm just coming back from Davos, where we have a collaboration partner, and in the course of allergic diseases, we also advise our patients to do medical rehabilitation, and one safe place are the Alps, for example, because we know that in the Alps we have lower birch pollen load, lower spore load, we have less bacteria on the pollen. And this means when we are losing these safe environments for our patients, we are losing also places where we can perform medical rehabilitation. So this means, in summary, we know that climate change is impacting on ecosystems and is impacting on pollen count and also on spore count. And this is inducing more symptoms in our patients. And this means also that we have also more allergics in the future because of climate change. And one possibility to change all this is, first of all, to mitigate climate change. But the second possibility is, and this is what I have to do as medical doctor, to treat the patients efficiently. And especially there is the possibility to cure allergies, and this is by specific immunotherapy. And this is what we are doing with our patients in order to prevent all these symptoms and to have this sustainable health when we have also our safe environments. And by this, I would like to stop, and I'm open for your questions.
Thank you very much, Claudia. So we'll hand over to Hannah for 2 questions.
Maybe I'll so thanks, Claudia. And I'll start with a question just specifying the understanding of the mechanism of the biodiversity loss. So how exactly does biodiversity loss cause more allergies? Because somebody asked whether it wouldn't mean less exposure if we have less nature around us. And maybe is it important to differentiate when the exposure should be high or low?
Very, very important aspects in this question. First of all, actually, I don't know whether really loss of biodiversity causes allergies. We know it's associated this. So whether this is hen or egg is still not really clear. What we see in patients with allergies, we see a reduced biodiversity of the microbiome in the gastrointestinal tract, for example. Yeah. So, but whether this is the cause or a result is still a matter of debate. But what we also know is that we have specific bacteria that are protecting us, let's say, and there are other bacteria that are also paving the way towards Th2-dominated immune responses. So I think the answer to this question is very complex, because I think it's for most specific bacteria then really the biodiversity that is then causing the disease. And this is, on the other hand, the reason why we have to identify those. I think it's more a cocktail of different bacteria that are also preventive for the development of allergic diseases.
The second question also about the mechanism, but about the changed climate conditions and how they lead to more allergenic pollen. So in which way are pollen changed, or do you know?
Yeah. So this is again something we investigated in our climate chambers. We see that the pollen that are exposed to CO2, for example, or to nitric oxide, but also to ultrafine particles, for example, these pollen, they release more of this protein. When you remember this film I was showing, this red bullet, there is more of this red bullet when the pollen are exposed to these environmental factors. And also drought, for example, is also increasing allergenicity, which means they are releasing more of this allergen. On the other hand, we have also more pollen, for example, and we have longer pollen season. So it's we have not a season, but the whole year the pollen are flying.
Okay, thank you for so far. I mean, there are way more questions actually. I've seen it as well, but we'll keep these for the end. So I'll hand, or do you want to say something more, Claudia?
I can also answer the questions now in the chat because they are quite specific, and I'm really happy because it means that people understood a lot, and I will answer them also in the chat.
Thank you very much, Claudia. So I will hand over to Thomas Münzel now. Thomas Münzel is Chief of the Department of Cardiology at the University of Mainz, and he's focusing in his research on the connection between environmental risk or of environmental factors and cardiovascular disease. And he's also a member of a WHO working group on air pollution and health. And he recently published a work also on transportation, noise pollution and cardiovascular disease. So quite two really important risk factors as well. So we're going to hear a little bit more. Thomas, I'll hand over to you.
Yeah, thanks for this kind introduction. I'm very happy actually to have such a great audience, and the numbers are very high, unusual also for Zoom meetings. As you've heard already, I'm interested in cardiovascular risk factors, which are actually not acknowledged as cardiovascular risk factors yet. So noise and air pollution, we talk a lot about it, but if you look in the guidelines of cardiologists, you will almost hardly find any mentioning of these very, in my mind, very important risk factors. So I think it's very important now, and as I write here, a call for action to change this. There's actually huge interest in noise pollution and in cardiovascular disease, and just as recently published in The Scientist, a very nice cartoon, which I like to show to you, that here you see the aircraft, and of course it's disturbing the sleep, and this is one of how cardiovascular disease actually occurs, and this causes then cerebral disease, which is not so known actually, and also affects the cardiovascular system. So the WHO and the Environmental European Agency actually state that 1.6 million healthy years are lost per year in the western part of Europe. 70 million Europeans are living in towns and cities exposed to noise levels excess of 55 decibel, where people are saying this makes you sick, mainly cardiovascular disease. The EEA states that we have 900,000 cases of hypertension per year, 43,000 hospital admissions, and more than 10,000 premature deaths per year. Now, the question is, how can noise be translated in cardiovascular disease? And there is actually a nice noise reaction scheme, which was published in the European Heart Journal, mainly by Wolfgang Babisch from the Environmental Agency in Berlin. So here's characterizing two pathways, the so-called direct pathway, which means when we have very high decibel levels, more than 100 decibel, for example, then you get a direct, or we have the so-called indirect pathway, which means 50 to 60 decibel, which is around when we talk to each other. Then you get a disturbance of activity, sleep, and communication, and this causes cognitive and emotional responses, and actually can cause this so-called annoyance or anger reaction, and this is characterized by stress responses. So we can measure increased circulating cortisol levels, and we see an activation of sympathetic nervous system. And the important point is when we have chronic stress, we generate cardiovascular risk factors on its own. So we get an increase in blood lipids, blood glucose levels, activation of blood clotting factors. And we see an increase in blood pressure. And if this is getting chronic, we see stroke, heart failure, and ischemic heart disease. And the question was always, how is stress being translated into cardiovascular disease? And this was actually the focus of my group in noise research within the last 10 years. Now, when we check the different transportation noises, what is most annoying, then we always see that the aircraft noise is more annoying than road and railway noise. Here you see the decibel level, 65 decibel. Here you can see, just a moment, how can I go back? How many people are highly annoyed in percent, and you see aircraft noise always causes more anger than road or railway noise. Now, annoyance is also causing arrhythmia and cerebral disease. In Mainz, we have the Gutenberg health study. It's a prospective cohort trial like the Framingham heart study, for example. We have included 15,000 participants, and we have published just recently that with the increasing noise annoyance, you are more likely to get atrial fibrillation, which explains why you're getting also more strokes. And we see an increase in depression and generalized anxiety disorder. So it means when you have extreme annoyance reaction to noise, the likelihood to get depression is almost doubled. Now, the important point is so far people were saying annoyance, it's just an anger reaction. It doesn't mean anything with respect to prognosis until this beautiful paper was published in European Heart Journal, Neurobiological Mechanism Linking Transportation Noise to Cardiovascular Disease in Humans. And what the authors from Harvard did actually, they found that amygdala activity correlates well with vascular inflammation. So amygdala are known to modulate fear and anxiety responses in humans. In the study, more than 500 subjects were screened, exposed to high noise or low noise. And you see here a PET-CT investigation. You see here the amygdala lightening. And the important point is there is a nice correlation between noise level and amygdala activity. And they also established in the aorta ascendens that there's evidence inflammation in those who had amygdala activation, but not in those who had no activation. So increased noise exposure was associated with higher amygdala activity, vascular inflammation, and MACE. And you here see the Kaplan-Meier curve, and it shows when you have noise less than 55 decibel, then the likelihood percent survival is much, much better than when you have more than 55 decibel of noise. And the important point is this in results also indicate that, for example, resilience is a very important modifier, whether you get sick or cardiovascular disease in response to noise. When you have chronically lower amygdala activity, the risk of MACE is greatly reduced. When you have higher amygdala activity, you have a higher risk of MACE, which means cardiovascular death, myocardial infarction, heart failure, coronary and peripheral revascularization. So the important message of this paper was resilience training may actually help the people to fight noise consequences for the cardiovascular system better. Now, as a consequence of noise, we have hypertension, coronary artery disease, heart failure, and stroke. And I just want to give you some hint that nighttime noise might be more important than daytime noise. This is a hyena trial, multi-airport trial, which was done in Europe. And you see actually the results nicely show that when you have nighttime noise, you have a significant increase in the odds ratio to develop hypertension within 10 decibel, and you don't see significant increase in hypertension in response to daytime noise. Another important study which was just published this year, and usually we say when we have noise, we have chronic stress, and this is a disease which develops over years. And this was the first hint actually that aircraft noise can trigger acute cardiovascular death. It was a study done at the Zurich airport, and the important point was that nighttime aircraft noise 2 hours prior to the observed events actually indicated that the people had more death due to acute myocardial infarction, heart failure, and overall cardiovascular disease. So the concept is when you have nighttime noise, this causes a release of stress hormones because of the emotional response, and important triggers for acute cardiovascular infarction is a high heart rate and high blood pressure. So that's a concept between these acute cardiovascular deaths. Now I want to say something to the pathophysiology. How can noise actually cause cardiovascular dysfunction? So we worked together with sleeping experts, and we simulated the aircraft noise with an MP3 player. This was done as a field study, which means the noise was presented in the house of the study participants. We had peak decibel level of 60, mean decibel levels of 43 and 46 decibel. And it was an original noise from the airport Cologne Bonn. And we had also polygraphic screen devices where we can derive heart rate and blood pressure. And what we also did, we measured endothelial function. And just for those of you who are not familiar with this biomarker, it's an inner lining of the vessel which produces nitric oxide, which is very important with respect to make the vessels dilate, to make them more compliant. And the important point is that shear stress actually releases nitric oxide. When we have cardiovascular disease or risk factors such as diabetes and hypertension, we have more superoxide. And this is eating up nitric oxide, and you see that on the right side, nitric oxide reacts with superoxide to get peroxynitrite. And this is damaging the endothelial nitric oxide synthase, which means it uncouples the enzyme. It's an enzyme with two phases, making an enzyme from anti-atherosclerotic to pro-atherosclerotic characteristics. It inhibits the signaling of the smooth muscle cells, and it can actually inhibit prostacyclin synthase by causing a tyrosine nitration. So that's a very important mechanism, how endothelial dysfunction occurs, oxidative stress. And the question was, is noise and air pollution doing something similar? So we studied this experimental noise setting in medical students. We have seen actually 30 or 60 noise events are actually causing endothelial dysfunction. We could correct it by giving acutely vitamin C, indicating that high oxidative stress occurs in the vessel. We have seen actually that the pulse transit time is getting decreased, which means sympathetic activation of the vasculature, and we see also an increase in stress hormone. Adrenaline levels go up, and we just recently summarized this in Nature Medicine because we developed an animal model, a mouse model, which we exposed also to aircraft noise, and we were able to realize the pathophysiology behind noise-induced cardiovascular disease. And I want to go with you quickly through the results. So the first was that we identified vascular dysfunction, high oxidative stress, and inflammation. So aircraft noise in mice increased blood pressure, which was not surprising. We have seen that also in our patients. We see an increase in stress hormone levels, noradrenaline, Ang2, and serum adrenaline levels went up. We have seen evidence for endothelial dysfunction. So we can take out the aorta of the animals and use acetylcholine, which makes a receptor-dependent nitric oxide release. And interestingly, just after 1 day, we see already endothelial dysfunction in these mice exposed to aircraft noise. We've seen that NO production is significantly reduced. And we see an increase in constrictor sensitivity. So we see in general a situation where the vasculature relaxes less and is more enhanced for vasoconstriction, which of course can cause coronary artery spasm and also arterial hypertension. And we've seen a huge increase in nitrotyrosine level, which reflects oxidative stress. And we have seen an increase in endothelin levels, which means more vasoconstricting agents are produced in the endothelium and in the smooth muscle. And we summarized this in a cartoon. So the concept is that aircraft noise releases stress hormones. This causes endothelial dysfunction by stimulating the production of reactive oxygen species. And an important point was that in all these investigations, we have seen a strong increase in NOx2. It's an NADPH oxidase enzyme, which is sitting in inflammatory cells and producing a lot of superoxide. So the concept is, if you have chronic stress, you get a lot of accumulation of inflammatory cells in the vasculature, but also in the brain, causing cardiovascular and cerebral disease. Now, an important point is that sleep duration predicts cardiovascular outcomes. So when you sleep less than 6 hours, or when you have a frequent interruption of sleep, you will get cardiovascular disease. And from the hyena trial, we know that nighttime noise is much more damaging than daytime noise. In both studies in Greece and France, we have seen that people develop more arterial hypertension. And we studied this day and nighttime noise issue in our animal model. We've also checked for cerebral effects, and also we tested whether a NOx2 knockout may be protective. And this is summarized in this cartoon. Actually, genetic NOx2 deletion, interestingly, completely prevented side effects induced by noise in these animals. And we have seen also that there is essential clock dysregulation, but also dysregulation of the vascular clock. We have seen an increase in oxidative stress in the brain. This is very important. And we have seen a downregulation of the neuronal NOS, which is a very important enzyme for learning and memory. And this may explain results from Stensfeld, who published in the Lancet, when children are exposed to noise, that they have an increased noise annoyance, but at the same time, the reading capacity goes down. And this nicely fits to our observation that this neuronal NOS is downregulated in the brain. Now, the important point is noise and air pollution have many of the same sources, so that there are links between noise and air pollution and the socioeconomic status. And research suggests, as published by the European Union, that the social costs of noise and air pollution, including death and disease, could be nearly €1 trillion and exceeding the costs of alcohol and smoking by far. Now, where's the pollution coming from? So we have natural sources, lightning, volcano eruption, and the wildfires like we see in the US. Cities are very important pollutant source, fertilizer, oil and gas, of course. Then we have industry and power plants, and we have the mobile fraction like airplanes, cars, and trucks. Now, when we talk about air pollution, then we have to know that we have gaseous and solid components. So in Germany, nitrogen dioxide is very important, ozone also, and we have the so-called particulate matter. So with different sizes, 10 micrometer, 2.5, and the so-called ultrafine particulate matter with 0.2 micrometer. And this actually has the size of a virus, while 2.5 micrometer has the size of a red blood cell, and 10 micrometer the size of a cell. So the important point is, with respect to for deaths or cardiovascular deaths, that ambient particulate matter pollution has already ranked number 4 in 1990, and in 2015 it ranked number 5. So actually it's a very important cardiovascular risk factor, also just behind high blood pressure, smoking, high glucose levels, and high cholesterol levels. And the interesting point is that the cardiologists are not mentioning air pollution in their guidelines as important risk factors. Even air pollution causes mainly cardiovascular disease, such as ischemic coronary heart disease and stroke. So in the publication, European Heart Journal, we summarized the pathophysiology of particulate matter. So when you inhale it, when you have nanoparticles with 0.1 micrometer, it can go directly into the brain and activate systems which can cause acutely high blood pressure, but it can also transmigrate into the bloodstream, taken up by blood vessels, causing endothelial dysfunction, platelet activation, systemic inflammation, which causes at the end atherosclerosis and cardiovascular disease. Important also that air pollution in particulate matter can increase cardiovascular risk factors. So we have seen an increase in stress hormone release. We have seen evidence for increased diabetes, so increases in blood pressure. Now, how important is the contribution of air pollution to cardiovascular, or to the overall death? So the WHO estimates that around 7.2 million die because of smoking. And we just recently calculated that almost 8.9 million people are dying because of air pollution, excess death. In Europe, we have a fraction of 800,000 deaths. 40% ischemic heart disease, 8% stroke, and around 20% lung disease, such as pneumonia, COPD, and lung cancer. When we check now for mortality rates, we see actually that Germany has a very high one, which is clearly higher than the European Union, Italy, or even Poland and United Kingdom and France. Now, what is the worldwide perspective? So when we check how many years do we lose because of air pollution, then we see here in the US, it's around 1.6 years, Australia 0.8, China 4.1 years, India 3.9 years. And the important point is how compares air pollution to other diseases. So all ambient air pollution reduces life expectancy by 2.9 years. Tobacco smoking just by 2.2 years. Then we have household air pollution reduces life expectancy by 0.7 years, and other diseases where we believe they are very important. HIV/AIDS reduces life expectancy by 0.7 years, meningitis by 0.3 years. So I think there's no doubt there's time to act. So we have the environmental noise guidelines, which actually indicate that we have to have very low levels, noise levels in particular in the night, where we know that most of the cardiovascular disease actually occurs. So these levels are very low and hard to fulfill actually. The WHO actually states that 91% of the world is living in an environment which exceeds their recommended concentrations, being healthy, of 10 microgram per cubic meter. Europe, interestingly, has a very high one with 25 microgram per cubic meter. USA, Australia, and Canada are clearly lower. Now, how can we personally mitigate air pollution side effects? Of course, we can stay indoors. We can avoid polluted areas. We can take agents such as statins or ACE inhibitors, which may ameliorate the cardiovascular consequences of air pollution. And we can do exercise. And just recently it was published, when we do exercise in a concentration of 25 microgram per cubic meter. So that's a limit we have in Europe actually, that you die earlier. So when you do exercise, you have to do it in a, let's say, clean environment. Otherwise, you are damaging your cardiovascular system. So at the end, let me tell you something about the importance of a healthy city design. 2/3 of the European population live in urban areas, and this is continue to grow, and the world population is estimated to reach 10 billion people by 2050, and 75% of those will live in cities. 60 to 80% of final energy used globally is consumed by urban areas, and 70% of greenhouse gas emissions are produced within cities. So city planning is now recognized as part of a comprehensive solution to tackle adverse health outcomes. And the WHO recommends, because of the high number of people living in cities, healthy urban planning is about planning for people. And we just recently published a review concerning this topic. And I like to remind you, genetics loads the gun, but the environment pulls the trigger. Thank you very much for your attention.
Thank you very much for your presentation and this very precise last sentence. Hannah, do we have questions? I guess so, but...
Yeah, of course we have questions. Thanks, Thomas, for showing even more harmful sides of pollution, such as pollution caused by planes. And also thanks for the important point on social justice and multiple effectiveness or multiple burden. We have questions about, well, is there a difference in the stress level when the decibel level is the same, but there's one noise one likes more than another? And then the second question, very similar, is there an adaptation to noise when you're exposed to noise for a very long time?
These are very important questions. So if you like noise, there are some studies actually showing to get less activation of the limbic system of this amygdala. So the cardiovascular consequences are clearly less. And the second question was again?
So is there an adaptation to noise when you're exposed for a long time?
That's a very important question. So actually we did a study with respect to vascular function. So we exposed subjects to noise and repeated this exposure. And we've seen when you had the experience of noise already before you get your second time your exposure, then the deterioration of vascular function is much stronger. So there's no tolerance to noise. There's more super sensitivity to develop vascular dysfunction. So it's more damaging actually. No tolerance, unfortunately.
Okay. How do you think we have to work towards including the findings you talked about in guidelines and in clinical practice? And what is your experience in this field?
So what we do in Mainz, of course, is when patients are coming in our chest pain unit, of course, we ask them whether they live close to the Frankfurt airport, whether they are heavily exposed to aircraft noise or to noise overall. And the important point is what we've seen is in animal models, when you have already, when you have a hypertension model, or you have a heart failure model, or you have a diabetes model, that always when you have, in addition to that noise, it doesn't matter whether it's railway noise or aircraft noise or road noise, then you get a strong increase in the severity of this cardiovascular risk factor. So when you have high noise exposure, I think it's wise to visit often your cardiologist and to check your cardiovascular system, measure the blood pressure, and check for your coronaries when you are in the HP above 50 years or so. And I think, as I said, it's very important that we acknowledge that these are cardiovascular risk factors, and we have to mention it in the guidelines. And I think when in the guidelines, noise and air pollution is mentioned, then the politicians have to take care for it and be more, let's say, careful in fulfilling the recommended limits for air pollution. So in Europe, it's ridiculous high that we have 25 microgram, WHO recommends 10. Why do we have 25 in Europe? So this makes no sense. Yeah. Because when we introduce the limits from USA, 10, then we have a reduction of 50% mortality. So instead of 800,000 people, die 400,000 people. So actually, when we talk about pandemic and check how many people died because of COVID, and if you consider that almost 9 people died because of air pollution, so we have two pandemics, so the air pollution pandemic and the COVID pandemic. And the interesting aspect also is that these air pollution particles are being supposed to transport also the COVID virus. So it may be also a spreading factor.
Yeah, impressive numbers. Clarissa, you had a question to Thomas, I believe. Is that right?
Yes. Hi, Thomas. Thank you very much for this very nice presentation. I really think it's extremely important and impressive given the overburden of non-communicable diseases, obviously. So I was just a little bit surprised about this concentration, the high all ambient air pollution in the western parts of sub-Saharan Africa. So why is that so high? Because that's not indoor pollution, right? It's ambient air pollution. So I was just wondering, is that climate related rather than?
I think it's climate related, yeah. Also you must consider, I'm a cardiologist. I'm working together with Joost Lelyveld. He's an atmospheric chemist, so he has all the models how he's calculating the degree of air pollution. So I'm pretty convinced it's the climate, the dryness, and the dust, which is causing this very high numbers. And the interesting point is also that we have these desert storms. And actually, these desert storms, Sahara storms, the sand which is transported to Europe, is actually accountable for 20% of excess mortality of air pollution in Europe. Dust from Africa is killing European people in a very high number.
That's interesting. Yeah, thanks you. Thanks a lot.
Are there any further questions, Anna?
Martin, did you want to say something? You were muted.
Do we have more time for a question, or should we move on? I think we have to move on, huh?
If there's one more question, I would take one more. As Thomas,
Let's take a short one, a very short and practical question about noise pollution again. So would you recommend to sleep with earplugs if we live in a noisy area?
That's the normal questions we get, earplugs and earphones or so. I think that's a reasonable question. I'm not aware of any studies who investigated the effect of earplugs on cardiovascular system, but I'm pretty convinced when you like it and you're used to it, I think it's a great advantage. I tried on myself, but I always had the feeling when I have the earplugs, I'm more under stress because I'm listening more. Do I hear something or not? Because I'm wearing this earplug, so it didn't help me very much, but of course, if you are used to use earplugs and they help you, then it's of course an advantage.
And for me, I think there's also still the challenge if you need an alarm clock and you have earplugs, then the question is, what is more important? Waking up at time.
That's right. That's right. That's right. That's right.
Okay, thank you very much, Thomas, for your great talk as well. You need to leave earlier, so you won't be there for the discussion, but thank you for joining, and I will hand over to Martin, who's introducing Clarissa. Bye. Yeah,
but before also thank you again, Thomas. Both you and Claudia and also Clarissa are great examples of the emerging pool of lecturers around the writing of the book and bringing out the messages to more and more people. And I assume we will have a lot of work to do in the next years jointly, because there are hundreds of thousands of doctors and medical professionals who need to be educated about these things, to be advocates for the change that is needed. So it's also in all your talks, it's clear the connection between the environment and us and the global and the local and the city planning and all of it. So we are seeing the complexity of interactions. So thank you very much. And now I'm very pleased to hand over to you, Clarissa. We have met 3 years ago when you were in the process of founding the Global Health Center for Global Health at the University of Munich. You are also a medical microbiologist, an immunologist, an infectious disease expert, long-term lecturer, and co-founder of this Global Health Hub. And since March 2020, you're a member of the COVID-19 expert team at the TUM Teaching Hospital in Munich. So great to have you here. I want to ask with a question. You might remember 2 years ago, we were meeting at the climate strike in Munich, and you were going there with your class. So you are walking the talk of being a great scientist on one level, but also joining kind of the actions on the street. Perhaps you might share in the beginning, what is your experience of living in these two worlds of activism and science?
Yeah, thank you very much, Martin. I think it's a very good question, and it's also a question that is possibly not really easy to answer, or maybe very easy to answer. On the one hand side, as a scientist, you and Claudia knows this very well. For a very long time, you're almost forced to work in silos, and you need, of course, excellent publications and so on and so on, and no nature, no money. Everybody knows these talks and or concepts or beliefs rather. And but then I would say it's a process for us old schoolers, I would say, and honestly, I mean, I have 2 children. One is just doing his Abitur. He's also sweating. So tomorrow it will be finished. And I mean, of course, having children of your own is one point that sort of makes you reflect possibly a little more. But But personally, I have to say, my initiation also towards global health or thinking in an interdisciplinary manner or multidisciplinary manner was already instigated during my studies. And that was clearly, I had a teacher, he was a lecturer in tropical medicine, but his lectures, and that was the specialty, and he got prizes for that as well, were that he looked at diseases in a very comprehensive and very interdisciplinary manner. So his lectures on leishmaniasis, whatever, would start maybe with a political statement or a social statement on poverty, for example, right? So, and that I've always kept that at my heart, I would say, and I took over later on his position and continues his lectures and try to develop also, you know, into my style into that direction, to really teach young students not to, you know, look at problems in a very siloed manner, but, you know, to open your eyes. And that's also why we joined this protest march when we had I have every year, I have a course on medicine in the tropics and global health with medical students. And yes, and I can only say and agree with Claudia, what she said in the beginning. What can we scientists do and really help support the action is to do things what we can do. We can look at scientific papers, we understand them, we can interpret them, we can pull the information together. For example, in writing book chapters. I mean, I was not born an activist for sure, and maybe I will never be, but I can contribute. And I think that's what really I found excellent. And thank you very much, Claudia and Martin, to bring me here on board and letting me be part, because I think this is truly a possibility to contribute. And yes, having said this, I think I will leave it and yeah, and then just start my lecture. And it is, we've now heard 2 lectures, excellent lectures, on how climate change can impact the so-called, what we group as non-communicable diseases. And obviously, as you can imagine, they also have an impact on infectious diseases, so the communicable diseases. And you all know, and some of you have seen these graphs before, that the communicable diseases are on the retreat, especially in Western countries, and the non-communicable diseases are taking over. But nevertheless, if you look at a whole continent, that's Sub-Saharan Africa, communicable diseases still are 60% of all deaths, cause 60% of all deaths in these areas. And unfortunately, though, there is also something that is called a double burden of disease. So they don't only suffer from communicable diseases, at the same time non-communicable diseases are increasing on top. So that means they don't have either or, but they have both. And this is causing, so from a global perspective, a big problem in the future. Now, so how can climate contribute to this transition, or does climate have maybe an impact on infectious diseases that we here in the Northern Hemisphere and westernized high-income countries have almost considered as having combated completely? I mean, COVID-19 is teaching us definitely another story, and how we are all interlinked and how vulnerable we are in the end to such a global impact. And we all agree that climate change is also a global impact. And you have seen these in other lectures for sure, these climate scenarios before. And this is just to tell you that these kind of climate scenarios are obviously important, because they are also the basis of modelers, for example, to really try at least a little bit to look into the future and try to estimate what impact could climate change have, for example, on the spread of infectious disease or the re-emergence of infectious diseases. And here comes an important aspect, which is biodiversity. And how is biodiversity actually interlinked with infectious diseases? clearly, again, I can only cite COVID-19 here. We all know that loss of biodiversity, for example, if habitats are being destroyed, just look at rainforest, for example, if habitats are actually destroyed, that exerts an evolutionary pressure on species living there. So that only means conservation of intact ecosystems and their respective biodiversity reduces the spread of infectious diseases. And this has been clearly shown in many papers. Just to give you an example, in 2010, there was a huge outbreak of malaria in urban areas because huge land areas of forest were taken down. And this actually led only the logging of 4% of this regional forest led to a 50% increase of malaria in urban areas, simply because the malaria vector, the Anopheles, suddenly found a new habitat which was much more comfortable in the city, in the urban area, than in the forest, because the forest actually prevented their breeding. So let's take the example now. How do we lose biodiversity? I think land use is one of the examples par excellence in the end. So excessive land use leads to, in the end, to an evolutionary pressure. So we lose land, we lose biodiversity. That in the end leads to a shift, for example, as you can see down here, a loss of hunters, of mammals, of certain species, which in the end then leads to the increase of prey. There's a lot of young people out there, I know that, I can see that, and this is, in the end, this is school textbook knowledge, which we all are taught in 9th class, in 9th grade, and then again in 11th grade, and so on. And sitting in school and maybe university, you always think, okay, I read this in the book, but it takes place. It is there, and we can see it, and we can measure this very clearly. So loss of hunters, just an example, a hunter is, for example, a freshwater shrimp, which actually the prey of freshwater shrimp, they live on snails, freshwater snails. And freshwater snails are the habitat, are the main intermediate vector of a very important tropical disease, which is called schistosomiasis or bilharzia, which is increasing in a lot of areas. Or loss of amphibians as hunters. And amphibians, the main prey of amphibians are mosquitoes. And we'll come to that, keep that in mind. That's important for the examples that I will give you in a moment. At the same time, this increased land use, of course, increases the human wildlife contact. And again, we've seen this now with COVID-19, how big the impact can be. So on a local level, that leads to more suitable breeding conditions in human settlements. I'll give you an example in a minute. And on a regional level, so for example, expansion of street networks. That is one of the reasons, for example, in China, huge, that was not street networks, but that's train networks. Connectivity of people then obviously also leads to the transport of one infectious agent to the other, from one place to the other, much faster in much broader extenses than before. So, since we only have 20 minutes or so, I decided to just concentrate on 3 topics, dengue virus, West Nile virus, and in the end lose a few words on climate migration and tourism. So what are the relevant mosquitoes in general that transmit infectious diseases? There's not too many. There's the Aedes species, Aedes aegypti and Aedes albopticus, the tiger mosquito, as you can see here with this very nice tiger stripes. And then we have Culex species, and in the end, Anopheles. So there's not too many that transmit very important human infectious diseases. So what about those mosquitoes in Europe and the diseases that they transmit? So Aedes aegypti is the main transmitter of dengue disease, dengue fever, a few others. I won't go into them. And Culex in Europe transmit West Nile virus. Now comes a little bit the problem that Aedes albopicus, which is actually the mosquito which is inhabiting our regions, is actually a new transmitter of dengue virus and West Nile virus, and this is causing a problem, as you can imagine. Anopheles species, which is the only vector for malaria, so Plasmodium species, is actually also found here, but not the main species that transmit malaria as yet. We have ongoing transmission every year or the other in areas of Greece, Macedonia. So let's focus on those two, dengue and West Nile virus. So dengue. Dengue is a virus. It's caused by a virus. It's a flavivirus. It's an RNA virus, and it has a very short incubation period after the mosquito bites and sucks blood of 7 days, and then symptoms start. They last usually less than a week. So very short symptoms: high fever. People have arcing joint pains, high fever, headaches. So it can be very severe, but then the disease stops and is controlled, and you experience lifelong immunity. There are 4 different serotypes. This is why we still do not have a generally active vaccine. And actually, dengue virus causes 40% of the world's population is at risk. We are counting 390 million cases per year, which is double as much almost as malaria cases. Only 20 to 60% become symptomatic, and only less than 5% develop severe disease, especially if you have been infected by one serotype and then get infected by another serotype. However, we see an increase in incidence overall by a 3.2-fold, which is extremely important. And nowadays, the European Commission sees dengue virus as the most important vector or mosquito-borne viral disease affecting humans worldwide. And why is that? Because we are losing biodiversity, and that leads then to the fact that those mosquitoes that transmit find new peridomestic breeding areas. And if you consider now that more than 50% of the world's population is living in peridomestic areas, you can imagine how big the problem is, or can be, or even will be. So what about dengue worldwide? You can see the main hotspots are still in the southern hemisphere, but dengue has been introduced into Europe in 2010 because the vector is living in Europe and has become resident in Europe. There have been outbreaks in France and Croatia in 2010, big outbreak in Madeira Islands in 2012, and nowadays actually dengue is we see autochthonous transmission, so ongoing transmission throughout many areas in southern Europe. So what does the modeling tell us now? These are cumulative cases based on a mathematical model that takes into account temperature, precipitation, population density, and the GDP. And if we just flip through here and look at what happens, what will happen, or might very likely might happen with dengue, you see in the next 20, 30, 40, 50 years, we will see a start increase also in Germany. So meaning this is a problem and will be a problem. Looking at another important aspect that's more of a biological point of view, that is the dengue, concerning dengue, is the vectorial capacity. And what does vectorial capacity in the end mean? Vectorial capacity means how well can a mosquito actually transmit a disease. That has to do with vector immunity. I will not go into detail, but you see, this is the vector capacity of Aedes aegypti and Aedes albopicus today, as of today. Just look, if you just concentrate on Germany, for example, you see that in the next 70 years, this will change dramatically. So Aedes aegypti will increase even in Germany, and overall we'll have an increase of the vector capacity itself. So adding an additional problem to temperature and so on, urbanization, to this potential spread then of dengue fever. So taking together Aedes aegypti, even though this mosquito is the primary vector of dengue fever worldwide, because it prefers warm and humid climate, Aedes albopticus is evolving as a transmissible vector, secondary vector, but the problem is it's cold tolerant, its preferred hosts are mammals and birds. It has its breeding grounds outside of homes and has cold resistant eggs and is unfortunately already established in Europe. So this will be the main vector distributing dengue virus now and in the future, since it's more adapted to Europe. So next, coming to West Nile virus. That's also a virus that has been recently introduced into Europe, and it is a virus, it's again a flavivirus, RNA virus, which actually has been transmitted by migratory birds from sub-Saharan Africa and the Middle East, and then transferred to local bird population. And within this local bird populations has been fairly long has established a life cycle with another transmitter, which is a Culex species, Culex modestus. And from birds now there has evolved a bridging vector, which is Culex pipiens, and that is important because that Culex species in the end bites humans, and this is how West Nile virus, coming from migratory birds via local birds, has been now transferred not only to humans but equids. Any one of you who likes to ride knows this. There is actually a vaccine against West Nile virus, but unfortunately only for horses and not for humans. The course of disease is fairly similar to many flaviviruses. However, it's fairly unclear that after symptoms start, usually they reside, the classical symptoms of fever subside after 5 days, but there is the potentiality that fatigue and so on, a little bit of what we see with COVID-19 or long COVID is actually reported from West Nile virus, and it's not really clear yet and not really scientifically established and analyzed, but there is some reports out there that indicate that there is this long-winded post-infection process, which is not uncommon anyway to many viral diseases. So what do we know about West Nile virus? It has the widest geographic distribution of all arboviruses in the end because of the migratory birds. Only 20% of all people get symptoms. It overwinters in Europe since 2017 and has been endemic in Germany now since 1 year. 2018 there was a fairly huge outbreak with 2,100 cases in Europe, and leading to a high increase, for example, in Hungary of 15 times. And a study has actually tried to understand this outbreak in more detail, and has found that definitely those new cases were related to sufficient water surfaces, which were there in June, so very humid condition in the springtime, which led to the presence of wetlands. Increase then of the vector population, location of these wetlands under migratory bird routes, and presence of West Nile virus in the previous years was also an important factor. However, temperature anomalies then in July, because only then after that outbreak really started, were considered one of the main factors. And you all know these graphs. The last 4 years have been the hottest years ever recorded here in Europe. So temperature as an important factor also for the distribution of this disease. So in the last couple of minutes, I would like to say a few words about climate migration and also tourism or travel. Because that obviously, being an infectious disease specialist and a tropical medicine specialist, I mean, travel medicine is one of the important areas where you still need to think about infections and in preventing infections through vaccines or exposure reduction and so on. So are infectious diseases actually imported, and if they're imported, what role does migration play and what role does travel play in the end? Now, looking at traveling, I mean, dengue, again, coming back to dengue, is the most prominent example because it's the second most commonly diagnosed cause of fever in travelers returning from low middle income countries. There is a 60% increase in airplane passengers only within the last 10 years coming from epidemic dengue countries. So also from a global perspective, dengue is a big problem. I just can cite here the example of Singapore, which is a densely urbanized area where dengue is in the city itself, established itself, and has led to multiple rounds of dengue outbreaks. It's a big public health problem in Singapore, and Singaporean health officials really inspect living areas. So you get a fine in Singapore if you raise plants. And you remember that plant pot that I showed you, which has this beaker below, which is a breeding area. They don't need a lot, these mosquitoes, to breed. A breeding area for mosquitoes. You get a fine if you raise your plants like that in Singapore. So that important is the disease now at the moment. The most commonly caused or diagnosed cause of fever, of course, always is malaria. Is something that you as young doctors should never forget and not overlook if you have a young person with fever of unknown origin returning back from low and middle income countries. Dengue in Europe, all outbreaks are in the summer season, and some of the studies have really tracked back the origin, so mostly following viremic travelers, so people coming from being viremic and thereby being bitten by a mosquito, a resident mosquito, and thereby transmitting to another person. So if we now look at increased traveling, this cause being a risk for dengue outbreaks here locally, this also can mean that there might be an increased chance for adaptation of the virus to Northern Hemisphere in general. So why do people migrate? Coming now to migration, I mean, of course, there's social, political, demographic, economic reasons, but majorly environmental reasons, changes of climate leading to loss of crop, leading to loss of economy, leading into the vicious cycle in the end of poverty. And the World Bank is currently estimating that by 2050 we will have inland internal climate migrants of more than 70 million people, as depicted here on this slide. So a commonly asked question then is, those migrants coming to Germany, for example, oh my God, do they bring all these bad diseases with them, and then suddenly there is a spread and outbreak of infectious diseases then in Germany because of those migrants? And in the end, there have been, I mean, WHO has committed time and investigation into this important question, of course, and has recently come to the conclusion and published the conclusion that there's only a very low risk of refugees or migrants transmitting communicable diseases into their host population. And I think this is an extremely important take-home message if we now, discuss migrant health and migrant issues connected with it on a political level also. So especially because in Europe we have 10% of migrants, and of those even all over Europe 7 million refugees. What about migrants themselves and migrant health connected to infectious diseases? They are impacted by infections during their itinerary coming to Europe due to inadequate sanitary facilities. Just think of outbreaks of communicable diseases, of waterborne diseases, or diarrhea diseases in refugee camps. I don't know if any one of you has ever been in such a camp. This is not the place where hygiene is prioritized, unfortunately, at all. So, or another highly infectious disease is tuberculosis, and especially now in the era of antimicrobial resistance, where we have pan-resistant tuberculosis strains coming up and spreading worldwide. Even here, it's mainly the HIV positive migrants, but they often acquire tuberculosis only when they come to the European, the uptaking countries. So, meaning climate migration will increase for sure. This is projected by the UN High Commissioners for Refugees. And this is why I believe that migrant tropical medicine and global health in the end is gaining increasing relevance for us European doctors. And for sure, climate change is an important when we look and want to maintain planetary health, and planetary health itself has an impact on global health. And with this, I would like to acknowledge Philip, so not only my whole group, but especially Philip Patzelt, a young student, a really committed young student, only in his third semester of health science studies, who was important in helping me also prepare this lecture, preparing also the book chapter, which I would like to really take the opportunity to thank, and also give you all an inspiration and also a model of, do the right thing, go into that direction, do that kind of research, commit some time for that. And it is worthwhile, I believe. And with this, I would like to thank you, and I'm happy to take your questions.
Clarissa, thank you very much. Thank you so much for another great talk. So we directly take a few questions, and we will overrun this time, not because people intended to overrun, but it was so many things to share, so great presentation. So we take a few questions, and we have still 10-15 minutes for discussion. Please.
Okay, so I'll start right away. You talked a lot about the European situation. What about knowledge transfer and exchange between those countries that have great experience with these illnesses such as dengue, West Nile virus, malaria, etc., and those countries where these diseases are emerging?
Yeah, I would say this is why we need networks. This is why we need networking activities. That's why also one of the reasons why we founded the Center for Global Health, but I can also assure you that also the German government has acknowledged that we do not live in isolation in the end, and that interdisciplinary research on the one hand side, but also building capacity and building networks is an important topic.
Okay, then I'll ask several questions in one. So one part of prevention is the reduction of mosquito populations, and should one use repellents to reduce the transmission of vector-borne diseases? And if yes, what is the effect of mass repellent use? Mm-hmm. So what about biodiversity and human health in this context?
So good repellents I would always recommend to use, because for sure if you travel to the global south, for example, where you can acquire these diseases, you will not want to catch these kind of diseases, right? And there's also there has been development in this field, in this sector, obviously concerning repellents and the kind of repellents that are environmentally tolerable, I would say. And there's also hopefully some research continuing on that. And I'm sure because that research would also mean that dermatologists like Claudia and so on would be on board to develop these even further, because of course in the end you need to tolerize them as many other things.
Okay, thank you. Maybe I'll hand back over to you, Martin and Sylvia, for discussion, or?
Martin, you're muted. Martin, we
Can't hear you.
Perhaps also Claudia might want to react to your presentation. Claudia, you're now welcome to join the discussion. What I really love about all three presentations was this connecting the dot between molecular mechanisms and global kind of social dynamics. How it's kind of how you were seeing how these things are connected, and in all three very different areas of very specific research, but then kind of doing the connection between all of these things, what I would call connecting the dots, and also how mandatory it is to build up this network of scientists and researchers across the globe and across the different disciplines. So perhaps Claudia and Clarissa, you want to comment also what you took from the presentation of your colleagues today?
So if I should start briefly, I mean, I absolutely agree. And I think this is the way forward. And this is really how we can bring all relevant stakeholders on board, you know, and this is why I think it's also a great achievement, for example, in your book chapter, and this is something you should highlight, I think, is that you have basic scientists, you know, on board, like I said in the beginning, you know, that were used to working in silos, maybe not from the beginning, but yeah. And I think we took home mechanism. We're still, you know, we still want to see them, and I think that's also relevant, and that's also okay, because if we don't, I mean, we cannot turn back time, right? And we cannot turn back knowledge. We should use knowledge,
Absolutely.
Right? And this is why I think, and we should discuss our knowledge, and we should discuss common pathways in the end. I mean, what we saw about nitric oxide and stress, I mean, you know, and there will be common pathways on the one hand side, and therefore there will be, in the end, fairly easy solutions, maybe even, right? In terms of prevention.
Yeah.
So yeah, I don't know, Claudia, you want to comment here for sure as well?
Yeah, thank you, Clarissa. This is the nice thing for me from these sessions, that also I learn a lot. So about these infectious diseases, this is really great, Clarissa. So I took a lot for my daily life also with the patients. But concerning our new life as scientists in the connection of environment and also climate change and health, is this interconnectivity of things, but also of disciplines. So taking into account how we can understand the impact of environment on health. So we have to have these environmental scientists that are looking for meteorological science, but also long distance transport, for example, for our pollen, to understand how ecosystems are working and how all this is impacting on our health. So you know, this is how my life as scientist changed completely when I started to work in environmental science. As Clarissa said, it's not to work in silos. You really have to speak with biologists. You have to speak to every discipline in order to understand this, and then at the end also to bring this back to the patients. And this is why we are here today, because it's about the patient that we have to treat in our clinic, in our outpatient clinic, and to bring them, for example, risk apps, for example, to the patients that alert them when the risk is high for a certain disease. So this is how it then comes to the patients. And for this, for sure, we need this inter and also transdisciplinarity. And one last thing is also citizen sciences. So we are just today, we spoke about a project that includes also citizen sciences. And I think also this is important in this subject of environmental health sciences.
Yeah. Clarissa, I have one more question to you, which is you are also working on COVID, and you have clearly spelled out how COVID is connected, or the risk for COVID has something to do with kind of the changes in the environment and kind of with biodiversity. Now, it is still not understood by most people in the public how this is kind of true. It is not a simple kind of causing of it, but there is a hiring of the risk. Do you have any idea of how we can communicate this better? And of how this is connected to our field?
I mean, I think, loss of biodiversity means also, this is also mass breeding of animals, right? And I would try to communicate it like this. If you have mass breeding of only one species of animals, which happen to be very permissive for the disease, and in that case a virus, that can replicate massively in that animal, for example, it will cause for sure an outbreak because you have huge transmission probability then, right? That would be the first point. The second point, of course, is loss of biodiversity of ecosystems, loss of ecosystem. And this is what I try to also show you, that an ecosystem is always a very balanced system, and it needs multiple players, right, to stay in balance in the end. And if you now take away one actor within a system, for sure you will unbalance the system. And you can take these examples which have been out there in literature, where even a loss of a biodiverse forest, right? The biodiversity of a forest controls vectors, right? And if you take away that forest, right, you not only lose biodiversity, but that leads to an increase of that vector, right? And the last thing is, of course, then also the humankind itself, and how humans then actually get exposed once they take down forests, for example, which has actually in the history led to huge outbreaks of Chagas disease in South America, to leishmaniasis, which has become actually an urban disease throughout South America, right? So I think, we can draft something and really try to conceptualize this even better. But I think for me, this is absolutely clear. Yeah, monocultures, that is loss of biodiversity, will lead to a total breakdown of cycles, of hosts, of vectors. So yeah.
It's one of the learning questions for all of us. How do we tell the story to different audiences? So everyone listening now, please experiment with this, and let's come back with solutions and ideas, because the better we are able to kind of tell the stories in a way to different audiences, the more we can also point to the kind of solutions that are needed and to changes in behavior individually and collectively.
Honestly, this is why I said this also in the beginning. One of the eye-openers that I had was last year when I was sitting down with my younger daughter and looking at her biology book and what she had to do, what she had to study for the next biology exam, right? And that was biodiversity, and how biodiversity actually contributes to the ecosystem, right? And because that biodiversity means nothing less that you have multiple species right? So, and they all interact, and that's why they are there. And if you take away one, they really had to calculate what happens if you take away foxes or whatever, right? Then you have more mouse populations, right? Intermediate hosts of a certain disease. and then that can increase, you know. I mean, this is why I think we have all the knowledge and we even teach it to our children, but somehow we don't, I don't know, it doesn't lead to action, right? We know everything and we have known this long time.
But we are not connecting the dots, and we are not connecting the different players. So I think that's very important. And what I'm very excited about from today is this is our first kind of session which is focusing on three clinical disciplines, three clinical fields within internal medicine. And we are seeing how the molecular mechanisms and the global patterns are connected. And I'm very excited about that. We do this more because I think we have to go deeper with our molecular research, but being willing then to connect the dots on the larger scale. So I think this is just the beginning. So I'm very thankful for that. Claudia, you want to comment and then we will close?
Yeah, this is so the loss of biodiversity is like a common theme going through all diseases. So we have also, so in general, we have a loss of biodiversity on the skin of microbes when there is disease. And we are treating the skin and then there's a regain of biodiversity of the microbes on the skin. So it's really in the macro and micro environment, the biodiversity is important. And this is why it's at the end so simple also for intervention to increase the biodiversity or to save it in the environment.
Yeah.
Okay. Thank you very much, Claudia, for these closing words, I would say. And we will continue the clinical perspective for the next during the next session as well. And then we're going to focus on kind of the vulnerable or the most vulnerable groups of climate change and planetary health. So we're focusing on pediatrics, geriatrics, and on psychiatry. So hopefully, or I guess it will be really interesting as well. Thank you that everybody joined. And on talking about what Clarissa said, connecting the dots and getting from knowledge to action, I think that's kind of our credo for this whole lecture series. So I would say if you stay tuned and join us for all the next lessons, then after the next clinical one, we will have a more hands-on lecture again. And hopefully we'll kind of fill this gap from knowledge.
Just one more announcement, since we are in the first heat wave in Germany, we will have the heat symposium on Friday on the KLUG website. I will post it on the chat as well. Heat symposium for 3 hours with great experts again. So for everyone who wants to be prepared as a clinician or medical student or nurse, what to do so to save our patients that they are not dying from the heat wave in this summer, please join us on Friday.
Bye and nice evening.